in the DME part will be by Dr. Satish. He will tell us about DME diagnosis and biomarkers. Satish, over to you.
Thank you, sir. Okay, thank you, Dr. Malika, for giving us to share our thoughts on diabetic macular edema. So in the next 5 minutes, I'm going to talk about diagnosis of diabetic macular edema and a few pointers towards the biomarkers. The session goes on with the slides. The first is the evaluation of diabetic macular edema. As soon as you see a patient with diabetic macular edema, what do we do? And then we talk about the biomarkers. As Dr. Lalitarma has said, the diabetic macular edema is one of the most frequent cause of loss of reading vision in diabetic patients, and that is very important for us. And in Indian population, it has been noted that around about 18 to 28%, the prevalence of diabetic retinopathy is around about 18 to 28%. And around about 10% of the patients have either a diabetic sight-threatening problem, that is the diabetic macular edema, or the proliferative diabetic retinopathy. In the pathogenesis of the diabetic macular edema, you have to understand that it is multifactorial, and predominantly it is a VEGF-based and inflammatory mediated race, which causes breakdown in the blood retinal barriers, which causes accumulation of fluid, fat, and deposition of certain blood in the layers of the retina. And there is a neuronal disorganization which occurs, and which in turn causes visual impairment. Now, when you want to examine and diagnose a patient with a diabetic macular edema, you don't need any great tool other than a good 78 diopter slit lamp examination is a must. And I would recommend a dilated 78 diopter slit lamp examination. And a good 78 slit lamp examination will probably tell us whether the patient has got a diabetic macular edema. And as Dr. Lalitarma has already mentioned, the macular edema is whether we need to assess whether the patient has macular edema or no macular edema, and if he has a macular edema, whether there is a center involving macular edema or a non-center involving macular edema. But remember, your diabetic retinopathy evaluation is incomplete unless until you do not perform an indirect ophthalmoscopy, and it is a must to evaluate the peripheral retina, which is extremely important, for us to come to a correct modality of treatment for a patient with diabetic retinopathy. Of other investigative tools which are needed for evaluation, that is the fluorescein angiography, the OCT or the OCT angiography, or the B-scan. B-scan has got the least importance in evaluation of diabetic macular edema, but in a patient with a total media opacity like a total cataract, and if you really want to evaluate the traction of the macula, I think probably B-scan is one of the most useful tools. Now, as soon as you see a patient with a non-center involving macular edema, you really do not require an OCT much in this particular patients. Unless until you suspect a traction at the fovea. But all the non-central edemas, the fluorescein angiography is the indication where if at all you want to treat this particular patient with either a focal laser or you want to treat this patient with a grid laser, I think fluorescein angiography is a must. The need for fluorescein angiography has definitely come down, but definitely it is not out. All the non-central involving edemas, definitely fluorescein angiography has to be done. In another condition where the vision is not correlating with the fundal findings, and if you want to rule out an ischemia in the macula, FFA still has got a very useful role. And in conditions where you want to assess the peripheral capillary non-perfusion areas or in doubtful PDRs, and FFA has got a wonderful use. So once the patient, you identify a patient with a foveal involving edema, I think OCT is a must. Then if you suspect a traction, the OCT is a must. OCT is also used in the post-treatment follow-ups. Like as you treat the patients every month, once the patient comes back to you for a follow-up post-injections or post-laser once in 3 months, and at that particular point of time, you can repeat OCT. OCT, the advantage of the OCT is basically that it's a non-invasive tool, and then it's easier and it's highly reproducible. Now, there's another modality of investigation which we use is the OCT angiography combined with the OCT. The biggest advantage with this particular thing, which is an advantage for us, is it picks up the capillary non-perfusion areas in the macula much better than the fluorescein angiography, and that is. So, in nutshell, with OCT or OCT angiography, you're going to know the patterns of the edema, you're going to know whether there's a traction of the macula or not, and you are going to know whether the retinal layers are organized or not. So now this is the definition of a biomarker. This is the definition of a biomarker, but it is extremely difficult to cover all the biomarkers. And if you go back into the list of all the biomarkers, Predominantly, they are based on the angiogenesis theory, they're based on the inflammatory theory, they're based on the molecular theory, and they're also based on the genetic biomarkers, which are now, there are certain ocular biomarkers also. These ocular are the biochemical markers which are done even in the tears, aqueous, and predominantly they are again angiogenetic factors as well as as well as the inflammatory factors. But I will not go into details of all these things because of the paucity of the time. But what I can tell you is when you look at the ocular biomarkers, and the three important biomarkers have been given, which have got a pretty good sensitivity and specificity. One is the baseline visual acuity. One is the lens status and specific OCT biomarkers. I think the entire focus is going to be on the OCT biomarkers here because baseline visual acuity, the people say that if the patient has got a diabetic macular edema, patient has got very good visual acuity, let's say 6/9 or better prior to the treatment, the possibility that this patient will have good vision for a longer period of time is much higher. People with pseudophakics definitely tend to have a better resolution of the edema with steroids, but again, it is not very consistent. It's not a very sensitive biomarker. But let's look into the OCT biomarkers. Now, these are all the different OCT biomarkers. One is the intraretinal fluid, one is the subretinal fluid, one you have the presence of the hyperreflective spots in the OCT. The other one is the drill, which is called as the disorganization of the retinal inner layer, and then damage to the ISOS junction and the status of the vitreomacular interface. Of all these biomarkers, the most extremely sensitive, up to date, and the most predictive biomarker for us is the disorganization of the retinal inner layers. Suppose you find a patient on OCT, you have a DRIL findings, that is disorganization of retinal inner layers. The possibility of this particular patient landing up in a poor visual acuity is on the higher side. Vis-a-vis with, it is also noted that the reduce in the intraretinal fluid and subretinal fluid also increases the visual acuity, but it is not always consistent. Like we know patients where they have 6/6 and 6 visions, with still the patient having a diffuse intraretinal edema or even a cystoid changes at the macula, then you still see the patients having very good visual acuity. And similarly, in a status of the, when you look at the vitreomacular attractions, you can have a bad VMT looking, I mean, OCT, they shows a very bad VMT, but at the end of it, the patient still has a pretty good visual acuity. So they are not very sensitive biomarkers. So I'll just show you this picture, and the picture at the top, what you can see, this is the layers, the inner layers of the retina, which are got disorganized, and this is the drill. This is the subretinal fluid. Everybody knows a neurosensory detachment, and this is the intraretinal fluid. This is the cystic form, and this is the diffuse form. And this side is the HRS, that is nothing but the hyperreflective dots. These hyperreflective dots indicate either there are the inflammatory dots or possibly because of lipid dots, which can indicate a few hard exudates in the layers of the retina. So for me, the take-home message is to diagnose diabetic macular edema, you really do not need any great instruments. You just need a good 78 diopter slit lamp biomicroscopy examination. But remember, please do not forget not to do an indirect ophthalmoscopy and look at the peripheral retina, because that is an incomplete way of looking at a diabetic retinopathy patient. The second important thing is like when a non-foveal involving edema, I think FFA still is one of the most important tools which we use. A foveal involving edema, I think we have to use the OCT, and if you have an access to the OCT angiography, that is also can be used. And drill, that is the disorganization of the retinal inner layers, is one of the most important biomarkers to the present day, where the predictability of this particular biomarker is almost the highest. Thank you for your patient hearing.
Thank you, Satish, for this brief talk, but very, all the points covered. No hanky-panky slides. Let's have some discussion on this, because I think the bell has still not rung. So, one thing I wanted to know, why were you twice emphasizing that we need to see? I am discussing from the point of view of all the audience and comprehensive ophthalmologists, that twice you mentioned about we should always evaluate periphery with LIO in diabetic patients.
Yes,
can you unshare this so that
yes.
you can just press the unshare button.
Yeah, I'm. Yes, sir. So the reason why it is extremely important for us to look at the peripheral retina is majority of the VEGF production is occurring from the peripheral retina, sir. So whenever there is a gross capillary non-perfusion areas in the periphery, in the equatorial region or posterior to the equator or really anterior to the equator, this increased VEGF levels are responsible for the persistence of your diabetic macular edema. So one of the theories is that, like, if you want to really treat a good, if you want to complete the treatment of a diabetic macular edema, it is a must for us to look at the peripheral retina. That is, when I say peripheral retina, it has to be beyond the arcades. And another very important point, what we all miss is we are so focused on looking at the macula, whether there's edema, whether, especially this is for the general ophthalmologist. When they look at the macula, they just find few hard exudates, they find little edema and decided that, okay, let's go ahead and treat this particular patient. Now, majority of the times you can see multiple flat NVE, which are very easy for us to miss. So if you do a good...
Are we talking of LIO examination or ultra wide field angiography, so that you pick up CNP areas and
correct, sir.
NVEs and you see source of VEGF production?
Correct,
basic aim of your this was to highlight is are we dealing with any ischemic component in the periphery which are responsible for increased VEGF levels, and sometimes these factors may play a role in resistant kind of
macular
DME.
Otherwise, you may have surprises. You may treat the patient and the patient may not respond. And so it is better at the first instance to know what is the status. And it is easy for us to miss a PDR in these patients. And so it's a very important...
I agree. This point of, ultra wide field angiography and picking up peripheral ischemia initially came up with vascular blocks initially and targeted laser and those things. Diabetic also now people are talking about this. The other question was about, do you always do FAOCT in all patients?
No, sir.
In all patients who have diabetic comes to you for the first time with some degree of retinopathy by clinical examination?
Absolutely not. I do not do FFA and OCT for all the patients at all. For me, the indication for OCT is a foveal involving edema, or if I suspect a traction of the macula, and that is the place where I do the OCT for these particular patients. In a non-foveal involving edema...
let's ask other people also. Dinesh?
Yeah. Can I make a comment?
Yeah, Murli.
Just the last point, what Satish told, I would like to check it from there. I am a little bit more, my threshold for doing OCT in these eyes is very low.
Yeah.
If I see any evidence of hard exudates even away from the macula, I would like to order an OCT because it is such a simple, non-invasive tool. And in the present times, let's talk about present times, the COVID times. Let me be very frank with you. I do not spend much time with patients on 90D examination because of the factors, the fogging, that you are close to the patient, the risk of transmission is higher. My reliance of retinal examination today is more on indirect ophthalmoscopy and OCT whenever required, and even fundus photography, so that we minimize the time spent with the patients. I'm specifically talking about the COVID era. This is not, should not be applied to a normal practice. But in the COVID time, I've altered my practice to minimize the time that we spend on patients. So I would rather have the patients a fundus photos taken all quadrants and OCT done, and definitely do an indirect ophthalmoscopy for all patients. And the 90D examination would not be as diligent as I would have done in the past.
I agree. I think Satish was talking more about the overall this thing, and you are stressing more in the COVID time when you don't want to have too much time with the patient.
Yeah, I thought I just highlight. Yeah.
Yes, Shobhan.
Can I add one point?
Yeah, sure.
If you see on indirect ophthalmoscopy any hemorrhagic phenomena in the periphery, definitely besides OCT also order an FFA at the very first go in the baseline. So I would suspect peripheral ischemia.
Yeah.
So, and peripheral, maybe an early NV sitting in the periphery, which we might miss.
I think, Satish, first point I raised was this only. Peripheral
this is what I think Lalit meant when he asked.
Yeah. Yes, Dinesh, any other point to be added?
What I wanted to say was, I think what he was stressing on was that you want to pick up more than moderately severe NPDR, which is a clinical diagnosis, and indirect ophthalmoscopy is not a great way. What do you see on indirect? You specifically look in the nasal area. If you see hemorrhages and all over there, or microaneurysms not easy to see. Or if in just above and just below the arcades, if you see a lot of hemorrhages, please do a fluorescein angiography.
I think that point was very well stressed by Satish, that beyond arcade, one should always look.
Yeah, if you can't do this, if you don't know how to, and that's the problem, a lot of people don't know how to do indirect, then in that case, the alternatives to you are with a direct, which you want to avoid in the COVID area, or a fundus photograph, looking straight up, looking down, looking to the nasal side. That will give.
I would stress here the importance of photography, because photography is not only for diagnosis but as a teaching, as a counseling aid also.
Yeah, so I'm giving the alternatives in case you don't have one, you can do this. And the last one is, of course, the direct ophthalmoscope. The importance is to pick up neovascularization. Importance is not to pick up macular edema.
Yeah.
This is the important thing.
Ajit, any other point you would like to make in this? Any addition or subtraction? We'll not repeat here. Rajesh, where are you?
I want to ask one question. Drill. Drill is one issue which the diagnosis, I think, is an issue. The presence, if there are cystic cavities in the same area, you don't comment on drill. You comment on drill once there's only what looks like an amorphous mass without the layers defined in that area.
I think the photograph Dinesh showed was very good of drill without any cystic this thing, and that was a disorganized layers. That I think we will agree.
So that is what must be stressed, that you follow from the area where you can see the layers and see, can you see the layers in the area where you're labeling drill? If you can't see the layers separately, then only you label drill, provided there are no cystic cavities.
Yeah. Rajesh, any other words of wisdom you want to add?
So nothing more than all the stalwarts are saying, but the only thing is, like, I would like to add is the protocol W, which looks into the peripheral imaging by the DRCR net ultra wide field imaging will give us more evidence to really point it out that peripheral CNP areas and other things will definitely play a role.
I started with that only. So ultra wide field has a role. I think Shobit also stressed on this. Malika, would you?
So there is an audience question. Can you hear me?
Hello?
Can you hear
Very
me?
feeble.
Oh, okay. There's an audience question.
Yeah.
What is the clinical role of these biomarkers? How do they help you in deciding treatment?
I think Dinesh covered that. We will come to the biomarkers once we are coming to treatment. I think that will be covered there. Definitely, we'll take it up. Biomarkers is assuming more importance as the role of inflammation and steroids is increasing. So we will definitely take it up. But Satish has very nicely told that there are, these 5-6 types of biomarkers, and out of them, if you have to pick up either the drill or ISOS junction, they are the two important ones. Then we have HRF, SRF, and IRF. I think